So welcome everyone to the MRCPI online sessions. And here, Dr. Rabah, one of the MRCOG mentors, and now I joined the MRCPI team. So this file of questions, we are reviewing the most important or an example of the exam question, okay, very similar to real ones. Okay, and the exam questions for the MRCPI written exam part 2 written, as you will see, mostly are common practice, straightforward questions. So let's see how are we, what is the questions type, what are the important topics from the exam point of view, what are the recommended reading material or references for this exam, okay? So are you ready? Shall we start? Okay, so I will assume we are all here to start the questions. And the question number 1, my friends, is about a 32-year-old at 28 weeks of gestation in the day assessment unit. And she presented with skin rash and itching. On examination, there are erythematous, papules, and vesicles all over the abdomen, including the umbilicus and limbs, palms, and soles. What is the most likely diagnosis? So what do you think, my friends? This is based on the TUG article, okay, for reasons of itching of pregnancy and skin dermatosis. So this is a common resource between the part 2 and MRCOG and part 2 MRCPI. So it's, you know, a common question and it should be easy for everyone. So my friends, what could be, okay, here the diagnosis. If there is papules, vesicles, and it including the umbilicus. This is what we call it the pemphigoid, yes, gestationis, right? Why we are saying this? You know, my friends, I would like you to remember, okay, that in the older days, it has an old name. What is the older name of this? They were mistaken this vesicles to the herpes legion, right? Okay, so dear friends, simply, yes, you will remember in the exam for the keywords, it's the umbilical sparing is there. If the umbilical is sparing, you will go for the polymorphic eruption of the pregnancy. Okay, if the umbilicus is involved, then you will go for the pemphigoid gestation. Okay. Yes, question number 2 for a primary who is 36 weeks, come with abdominal pain with rapid upper quadrant pain. Blood pressure is 140/90, proteinuria 2+, glucose less than 2.2. Elevated liver enzyme. So what is your diagnosis? This is one of the most common questions that comes in the MRCPI. They like this question specifically. A repeated recall. Answers everyone. Okay, very well done. Okay, so what is the difference between the acute fatty liver of pregnancy and HELLP syndrome or preeclampsia? Yes, excellent, Dr. Madi. So this is the low glucose level. Okay, so This is why we think that this is acute fatty liver of pregnancy. Of course, there is overlap between the diagnosis of the three conditions. Okay, so here we will see patient can present also around the labor or in the third trimester, sometimes postpartum as well, with abdominal pain, vomiting, polydipsia, polyuria, encephalopathy, okay, plus or minus ascites as well, okay, but the hypoglycemia is there, okay, so that's why we are thinking that this is acute fatty liver of pregnancy. Thank you very much, my friends. Yes. Patient with pruritus and abnormal liver function test. She's known case of rheumatoid arthritis. After 6 weeks of postpartum, still the LFTs are abnormal. What clinical diagnosis is it? Anybody knows what is the clinical diagnosis? Yes, well done. This is the primary biliary cirrhosis. Since the patient, okay, have still abnormal liver function test, and still the pruritus continued after the 4 weeks, even 6 weeks of the delivery. So that means that there is something abnormal, especially that she have history of rheumatoid disease. So now this is we make indication for referral for a hepatologist, right? Why? Because people here in this case means that this is not just a simple cholestasis in the pregnancy. This is a complicated case, and that's why it need to be seen by hepatologist. Why it's not hepatitis? You don't have any leading word for the hepatitis. You don't have symptoms or risk for the hepatitis. But what you have here is a risk for autoimmune disease. She is already a rheumatoid arthritis patient. Okay? Clear, everyone? So answer is B. "16-year-old complain of continuation of bleeding during cycle, even after inserting tampon in the correct place." So the young lady, she is having cycles, she is trying tampons, and she's inserting the tampon. She expected that the bleeding stopped. However, no, there is a bleeding and maybe also large amount. Okay, so what do you expect? Yes, I expect that she have, yes, a uterine anomalies, okay, or she had longitudinal vaginal septum, okay, and this is, for example, okay, didelphys uterus, and she had longitudinal vaginal septum, as you can see here in the drawing, and she's inserting the tampon in one of these. Okay, so this one is blocked, but the other one is open, right? So that's why, my friends, she's have any tampons, right? Well done, everyone. So 16-year-old with primary amenorrhea, by scan, uterus is absent, ovary is seen, okay? And confirmed MRKH. What is the next investigation that you would advise? Yes, so and why we will advise the abdominal and pelvic ultrasound? So the answer is correct, of course, okay, but why we will advise it? Yes, because the chances of renal malformation, renal tract congenital anomalies, okay, is associated with the MRKH in around 40% of cases. So it's like a recommendation after the diagnosis of MRKH that you check also for the renal anomalies. A 37-year-old pregnant in her 34 weeks complained of difficulty breathing, of the left leg pain. Exam showed left leg tenderness. So normal right leg, what is the best next step? 37, 34 weeks. She had difficulty breathing. She had leg pain, okay? And there is tenderness. So this is like signs and symptoms of DVT, okay? Normal right leg. So what is the next step? So next step in this case will be bilateral complex Doppler ultrasound of the legs. And why? We do have the recommendation, and in this case, my friend, we use the acute management of venous thromboembolic event in pregnancy of the RCOG, the same RCOG resource. So pregnant woman with suspected pulmonary embolism who have symptoms and signs of DVT, she should have bilateral compression duplex ultrasound, okay, leg study performed. Clear, everyone? Any questions so far? So yes, we can see here that in some of the topics, we depend on the green top guidelines or the TUG articles. And actually, this is the majority of the resources to study, the MRCPI. However, of course, they have their own resources and we have to depend on that as well. So a primate complained of itching and mild elevation of bile acids. She delivered spontaneously at 37 weeks. What is the test to confirm diagnosis of cholestasis in pregnancy? We follow. So look, my dear, it's your name is Rakshanda. Is it correct? Am I pronouncing your name correctly? Okay, so everyone, yeah. So yes, you are correct. So the only way to confirm the diagnosis of intrahepatic cholestasis of pregnancy is the resolution of symptoms and normal test found at 4 weeks post-delivery. Yes, well done. 6 weeks was the old recommendation, Dr. Ayat. Okay, dear? Because we depend on the green top guideline of the intrahepatic cholestasis in the pregnancy, okay? And the confirmation of the diagnosis of intrahepatic cholestasis in the postnatal period at least 4 weeks after birth with resolution of itching and liver function test returning to normal, including the bile acids. Okay, so this is just a screenshot from the guideline. Okay, and my friend is asking why in the previous question a bilateral Doppler. That's because, again, this is just a screenshot from the guideline with the part of recommendation recommended that a pregnant woman with suspected pulmonary embolism should have symptoms, who have symptoms and signs of DVT, should have bilateral compression duplex ultrasound of the leg studies. Clear, my friends? So the question 8 is a pregnancy post-dated, admitted for induction of labor with Prostine. She had regular strong contractions, 4 in 10. She asked to review her. You are asked to review her after sometimes 4 hours per vaginally. You find that there is soft, fully effaced central cervix, head station at -1, os is open 1 cm. So what is your plan of management? Okay, so this will depend on what? How did you get the answer? When to choose repeat second dose of prostin and when to choose that you proceed with amniotomy. Yes, well done, Dr. Mariam. So well done, Dr. Aisha. This will depend on the Bishop score of the patient, okay? So here is the MRCPI, the Irish recommendation for induction of labor pathway for a woman, okay, with no contraindication and intact membrane using prostin, okay, vaginal gel. You record the history, note risk factor, conduct vaginal examination. And if CTG, no regular contractions yet, so In this case, if less than 7 and CTG is normal, I can advise repeat of the prostate. In the primary woman, it will be dose of 2 mg. In the multiparous woman, I will repeat by only 1 mg. So what about if the Bishop score is already more than 7? If it is more than 7 in this case, okay, what I will do is amniotomy, perform amniotomy when clinically safe to do so, and consider oxytocin. Okay, my friends? If amniotomy is not possible, but Bishop score less than 7, no contraindication, I can even consider giving another dose. Okay, so it's all depend on the Bishop score of the patient, how to proceed in the induction cases. So, Dr. Madi, my dear, there is another question in this exam, okay, is asking about the progress of labor for a patient who had been in the latent phase. So if the patient in the latent phase, okay, and what you will do, my friends, she is in the latent phase, you don't do anything, but induction cases, I have to follow the induction algorithm, okay? So I have to follow the algorithm of induction, and they have a special, okay, algorithm for induction using the prostate. Clear? So I have to follow the same sequence of the guideline. Clear, everyone? So the tip that I advise you here, that once the contraction is started, calculate the Bishop score based on it, you will proceed. Bishop score calculation is given here. So if you guys a little bit confused about it, okay, so you calculate the finding. Patient had fully effaced cervix, means that this is a score 3. The dilatation is 1. This is score 1, means that she is now 4. And the soft means now I have 6, okay, and the head station is -1, so now it's 8 even. Okay, my friends, so this is a very good finding. So no need to repeat the prostate. I can just continue the induction with the amniotomy, and that's it. I can consider oxytocin afterwards, but so far amniotomy will be the next step. Clear so far? I hope it is. So in a 39-year-old pregnant post-dated with history of grade 3 laparoscopic myomectomy was done. She was asking about her option if labor doesn't start spontaneously. For the induction of labor, it's a little bit there is a little bit difference between the RCOG or the NICE guideline of induction of labor, Dr. Aisha, and the Irish guideline of induction of labor. So in the NICE guideline, yes, if you have patient with Bishop score, it's more than 6, okay, so you can go or proceed with the amniotomy for the patient, okay, but it's not detailed like here when to repeat the dose of the prostate, what is the dose of the prostate, okay, so it's more detailed in the Irish one. So if you ask me if I wanted to study the induction of labor for the MRCPI exam, I will go for their Irish guideline. Okay. So what we will do for our patient here, she is a previous uterine surgery, means that I will do like a VBAC, right? Like a VBAC case. So if she is, if the patient, okay, does not have the spontaneous onset of labor, so what is her option? Her option, can I do induction or no need? Can I do induction? Is it possible to induce her or no need? Yes, I can induce her, of course. Same principles as the NICE guideline. Yes, can be induced using the mechanical methods, right? Yes, so I can induce using the mechanical methods. So in the previous exam, there was 2 questions coming from the induction of labor, the Irish guideline. However, as you can see, there is even a common ground between the NICE guideline and the Irish guideline in this case, not completely different. A primee in labor, okay, she is in labor room, and she is 38 weeks of pregnancy, and seen by obstetrician. Her os is 3 cm dilated, membranes intact, and it's a phased cervix with CTG normal, 3 to 4 contractions per minute in 10 minutes. She had history of myomectomy as well. After 4 hours of examination, okay, the os is still 3 cm. What is your next appropriate management? So what are you going to do for this case? Okay, so why I'm doing amniotomy in this case, my friends? Anybody knows? So here, is that a case of induction? If this is a case of induction, why delay? Do you have any recommendation for delay in the first stage of labor? Look, my friends, what is active labor? What is latent phase labor? Okay, so we do have in labor stage 1, stage 2, and stage 3. First stage of labor is divided into latent, right, and active. Active started in the NICE guideline from 4 cm with regular contractions, okay, and latent, and in the WHO, by the way, labor care guide started from 5 cm. In the latent phase means that the patient is still in the preceding labor, right? Okay, so what care I can provide for a patient who is still in the latent phase? Can I do any support to her? Can I give, okay, can I give painkiller? Yes, okay. So, you know what is the recommendation of the WHO in this regards? Yes, the epidural. Yes, yes. Okay. And here for the first stage of labor, okay, they depend on the definition of the latent and active first stage of labor. And this is the WHO, right? Because WHO care guide, the labor care guide, is important for the MRCUG in part 3 mainly, right? Rarely you will have questions in part 2 about the labor care guide, but in the MRCPI part 2 written or OSCE, they can ask you from the WHO labor care guide. So what is the recommendation? Okay, the recommendation just for the active first stage of labor, I can consider delay or recommended or confirm delay and then proceed according to the recommendation. But here, the patient is still in the latent phase. So if the patient in the latent phase, I can, okay, offer epidural, or I can actually, depending on the woman preferences, okay, I can recommend the epidural for her. So first stage of labor in low risk woman, epidural analgesia is recommended for healthy pregnant woman requesting pain relief during labor. And this is dependent on the woman preferences. Okay, so I don't need to expedite the birth in this case. Okay, since she is still 3 cm. In 3 cm, I don't do anything. Just make her comfortable, give painkiller or epidural, and just wait for the progress for this patient. Clear, my friends? In the RCOG, by the way, if you are still asking yourself what is the difference between the RCOG and the MRCPI, in the MRCOG is more conservative management. I don't do anything in the latent phase unless, okay, the patient requested. No need. No intervention before active first stage of labor, my dear. This is not a case of induction of labor. Okay, this is not a case of induction. This is a case of just normal progress of labor. She's in the latent phase. Cervix is not dilated. Epidural will not affect the dilatation of the cervix. Okay. I commented on the 4MR ARM. No, my dear, I recommended ARM or amniotomy in induction of labor, not in a spontaneous delivery with good contractions by itself. Right? So this is different. That's why two questions comes in one exam. The same idea as the EMQ when you have 1 or 2 points in the EMQ, okay, and based on or discussing the same guideline, but it's one of them is a little bit tricky, okay? Or just testing the deep understanding of the information. So here, yes, in the induction of labor case, and we explained the algorithm, Dr. Aisha, we go for amniotomy because this is the induction of labor. Okay? Two questions are there, and the two questions comes from the same exam. But one for management of spontaneous labor, the other one is management of induction case. Right? With the patient have 4 contractions, 4 in 10 minutes contraction. I didn't comment for anything. I didn't understand your question, Dr. Ahmed. I just give the answer. Guys, sorry for just want to show you the question again. Okay. Okay. So here, my friends, if labor, spontaneous labor is not progressed, okay, to active phase, in this case, I don't do anything. Okay. Labor may not naturally accelerate until cervical dilatation threshold of 5 cm is reached. Therefore, the use of medical intervention to accelerate labor and birth, such as extubation, augmentation, or cesarean before the threshold of labor or the active stage is not recommended, provided fetal and maternal conditions, okay, are reassuring. Auscultation using a Doppler ultrasound device or Pinard fetal cystoscope is recommended for the assessment of fetal well-being of labor on admission. Digital vaginal examination of interval, okay, of 4 hours is recommended for routine assessment of active first stage of labor in low-risk women, okay? Epidural analgesia is recommended for healthy pregnant women requesting pain relief during labor, depending on woman preferences. So I know it's a bit tricky, okay, but you guys should understand the difference between onset of labor, okay, which is spontaneous onset, or this is need for induction. The induction is different. Induction algorithm is different. So let's see. This is the induction algorithm. And this is for a patient who receive Prostin. Prostin effect will not last for long. Okay, so that's why I have to complement the method. That's why I have to follow the Prostin by the amniotomy for the natural release of the prostaglandins. But patient who have a spontaneous labor, she doesn't need more induction unless confirmed delay in the first, or even sometimes in suspected delay in active first stage of labor. Okay, guys, so you got the difference why the patient who had induction, we helped her with the amniotomy. The other patient who went spontaneously into labor with good contraction, why we give her epidural. By the way, there is a risk factor in this patient. Do you know what is this risk factor? in the patient here, this one, she had a myomectomy as well, okay, with good contraction, 3 to 4, right? So maybe giving her a little bit of pain relief can help her to proceed with labor comfortably without much pressure, right? Okay, guys, are we ready to go? Next question. In a 30-year-old primate who is 28 weeks of gestation presented to the ER with reduced fetal movement. After examination, her ultrasound Doppler and AFI normal, normal CTG as well, and now the patient feeling normal fetal movement. What is the next step in her management? She is what? Reassurance, repeat the CTG, biophysical profile, already done, induction of labor or expectant management. Yes, reassure and discharge. Yes, it's a common practice. Okay. And the Irish guidelines, they have a very nice, okay, algorithm for the management of reduced fetal movement. And the reduced fetal movement guideline, Irish guideline, is updated recently. So you will just know the initial response to reduced fetal movement. What is the initial response? Ask all women reporting reduced fetal movement to attend their maternity unit or hospital immediately for review. Don't delay assessment for any reason, including with non-evidence-based advice on methods to stimulate movement, such as consuming certain food or drink, or concentration on movement for a period of time prior to attending for review. So no delay at all, okay? No delay. Delay is not advised for any reason. Once she had fetal movement, reduced fetal movement, come to the triage unit or to the hospital. Initial assessment is by detailed history, okay? Details of the discharge in the fetal movement pattern, change in the fetal movement pattern, prior presentation, if there is any other associated symptoms like pain, bleeding, pre-existing medical condition, and risk factor for fetal growth restriction or placental insufficiency and stillbirth. Clinical examination include vital signs and symptoms fundal height measurement. Confirmation of fetal viability, you will auscultate fetal heart with the hand Doppler or Bernard. Initial investigation, you will need both CTG and the bedside ultrasound. So even if the patient, okay, even if the patient is coming for the first episode, I have to do CTG and ultrasound, okay? This is for all patients, not repeated, it's okay. Further investigation, okay? If concern raised at the initial assessment or discharge criteria are not met, in this case, senior obstetric review is recommended and consideration is given to admission and further investigation. Department ultrasound, fetal biometry, if not done in the preceding 2 weeks, Lycor volume, and please remember here, department ultrasound is different from the bedside ultrasound. Lycor volume and umbilical artery Doppler, time frame will depend on the clinical urgency. Fetal-maternal hemorrhage, if there is high index of suspicion of fetal-maternal hemorrhage. Discharge criteria, consider discharge to routine antenatal care if all of the following criteria are met. Okay. First, presentation with reduced fetal movement, no identified risk factor for stillbirth, normal assessment, CTG and Lycor volume, maternal concern regarding fetal movement have resolved it, and ensure appropriate advice given regarding further reduced fetal movement. So, means that here, my dear friends, the patient investigation covered or not covered, the ones that recommended in the guideline. Covered or not covered? Covered. Yes. Look, my friends, the bedside ultrasound, it does not aim, okay, to assess fetal growth or Doppler. The bedside ultrasound to assess the liquor volume and presence or absence of fetal movement. So I am doing a bedside ultrasound. No need for a specialist to perform this ultrasound, just to confirm the fetal viability and movement and assess the liquor volume. Clear? So in this case, the patient, she had CTG normal, she had bedside ultrasound normal, and the patient started perceiving the fetal movement. Now, this is meeting what? Meeting the discharge criteria written in the algorithm. So when he give you something like discharge criteria and he tailored the question to cover the discharge criteria, what does this mean? Means that you just want to make sure that you have read the guideline. This is what they want only. Consider discharge to routine antenatal care if all of the following are met. First presentation. This is first presentation, not repeated. If repeated, we will induce. No identified risk factor for stillbirth. Okay. Normal assessment. CTG and liquor volume. Maternal concern regarding fetal movement have resolved. Do I need to do any further investigation after this or just a discharge? Do you need? No, I don't need, because all the discharge criteria are covered. So just a discharge, right? Okay, so we are strictly following the guidelines, right? Whatever is given in the guideline, we will just follow. That's it. Okay. Here in para 1, previous SVD, 40 weeks in labor, patient progressed well to full dilatation. On the CTG, there was a bradycardia for 9 minutes. Fetal heart rate 60 per minute and not recovered. Os fully dilated, membranes absent, but the station is -1. What is the appropriate management? So once station -1 means what? No instrumental delivery is allowed. Yes, well done. Okay, so no instrumental delivery is not applicable here. Why? Because this is only -1 and we need at least a 0 station, correct? So the only option to be applicable here is the cut 1 cesarean section. If you just change the finding to say, for example, the head is station 1 +1 or even 0, okay, so in this case, we can do a trial in the theater, okay, moving the patient fast, urgently, right, and just to perform a trial in theater before you proceed to the emergency cesarean, yes, because it will be faster. Otherwise, -1, no trial. Patient with history of recurrent pregnancy loss, no reason detected. So what is your advice for future pregnancy? In the recurrent pregnancy loss guideline, the Irish guideline is a little bit different from the recurrent pregnancy loss guideline by the GTG. So they have different recommendation. Yeah, okay. So if the patient had a folic acid, yes, folic acid is a good advice. But you know also what the Irish guideline will advise? I can't never ever give, never ever give low molecular weight heparin and aspirin in any patient with no confirmed diagnosis of antiphospholipid syndrome. So never think about D. Okay. Folic acid is okay, but is it folic acid 400 in the Irish guideline? So let's see what the guidelines say. Look, my friends, this is the summary, okay, for the National Clinical Practice Guideline of Reduced Fetal Movement, the Irish one. For a woman with previous unexplained recurrent miscarriage, sorry, it's recurrent miscarriage. Woman with recurrent miscarriage at increased risk of placental dysfunction, and for this purpose, the low-dose aspirin is recommended in future pregnancy. Okay? With consideration of low molecular weight heparin when based on individual risk factor and history. So I never ever touch low molecular weight heparin without confirmed diagnosis, okay? Otherwise, aspirin can be given. Low dose is recommended in future pregnancy. High dose, 5 mg folic acid supplementation in an Irish context, it should be considered for women with recurrent miscarriage. So they consider the folic acid high dose for a recurrent miscarriage. Okay? In a woman with 3 or more consecutive miscarriage immediately preceding their current pregnancy, look, empiric progesterone administration of 400 mg vaginally twice per day may be of some potential benefit. So the recommendation is started from recommend. Which one recommend? And for recommend, I will give 1 plus plus. Which one you would recommend for recurrent miscarriage unexplained according to the Irish guideline? Aspirin. Yes, aspirin. Well done. Okay, low dose aspirin. So which one you will consider? And I will give consider 1 plus. Folic acid high dose. Folic acid high dose. Remember, it's folic acid high dose. Okay. Which one you will give empirically as it may benefit the patient, maybe benefit the patient. This is the empiric use of progesterone vaginally, 400 mg twice per day. As you can see, my friends, this is a complete different recommendation from the MRCUG. So if you are MRCUG candidate, okay, and I know that most of you guys commonly prepare the 2 degrees together, okay? Please take care that in the recurrent miscarriage guideline, there is a difference in this part, okay? So the answer that most applicable for this scenario is the aspirin and progesterone 400 mg twice per day. Yes. Yes, excellent. Well done. Okay, so guys, be careful. And if you have a choice of folic acid 400 micro, this is not the one to use in repeated or recurrent miscarriage. Okay, so female 32 weeks and her husband is 35 weeks. The couple diagnosed with unexplained infertility for 1 year. What is your management? What is your management, my friends? Yes, in this case, okay, uh, even if I added IVF to the option, okay, wouldn't be, maybe it was the 5th option in the exam, I am not sure. Okay. Are you sure? Okay. So if any of our friends attending have attended this exam, the March 2025, you can tell us whether the IVF was there as an option. Okay, even if it's there, what is the first line management of unexplained infertility in the MRCPI exam? This will be intrauterine insemination. Okay, so the intrauterine insemination is the first line management of unexplained infertility in the ISHRI guideline. And the Irish guideline also have endorsed the same recommendation. They even advised, okay, and they wrote what is the reference from it. So if I ask you, my friends, the intrauterine insemination with or without induction? Here is a guideline for the infertility management and the recommended treatment for couple with unexplained infertility. It says ovulation induction should not be offered for a woman to a woman with regular menstrual cycle who don't proven ovulation. Who have proven ovulation. Ovulation induction for women with unexplained infertility who have proven ovulation is not recommended. Intrauterine insemination with ovarian stimulation, okay, should be considered as a first-line treatment for couple with unexplained infertility. So here, what is the first-line treatment for unexplained infertility? First line is IUI for unexplained. If this is an MRCUG exam, what you will advise for MRCUG unexplained infertility, forget the word IUI, just remember IVF. But here, MRCPI exam says insemination, IUI, okay? Please be careful, take care of the difference. If you study both, again, just to note down the difference between this and that. No, in the MRCG, actually, the scenario usually will be a little bit longer with more details, and we will advise conservative management because IVF will be offered after strictly 2 years. Ovarian stimulation, yes. 38-year-old lady came with urinary incontinence on examination, diagnosed as a stress incontinence. Her BMI is 35. So what is the initial advice? That's very easy. Many of the questions, I can say more than 50% of this exam is very easy questions. With some that are a little bit twisted, some a little bit maybe new. If you don't study the Irish guideline, you will not get the correct answer. Because of course they focus on the difference between the guidelines. If there is a point of difference, for example, in the induction guideline, they will go for it. If they have a point of difference in the infertility guideline, they test you for it and so on. And it's fair enough. Yes, in this case, still, this is a common ground that the BMI 35, this is high BMI, so advise reduced weight and physiotherapy as first line of management. Well done. Patient pregnant at 20 weeks with her colleague, exposed to her colleagues who had shingles. She present now, and the patient have concerns for herself. What is the management of this patient? Anybody knows? Yeah, okay, so yes. Okay, so guys, why would you advise a cyclover? The question is, shall I give the prophylaxis, post-exposure prophylaxis immediately or test for immunity first? What do you think? Yes, the new guideline, my dear. Yeah, I would say something. I agree with you that the new guideline say that the post-exposure prophylaxis, okay, would be the acyclovir instead of the immunoglobulins, right? Right? And the immunoglobulins will be given if the acyclovir is not present or not available or not suitable for this woman, right? Okay, but the question here, this patient, she had exposure. Is she immune or non-immune? What do you know about it? What do you think? You will need to, you will need to test, right? Right? You need to check for the immunity. Otherwise, if she is immune, what you will do? Just reassure, right? So this is would depend on the immunity status of the patient, correct? And then after that, I can just proceed whether to give her post-exposure prophylaxis or no need, right? Patient pregnant 35 weeks with middle cerebral artery systole high. Mm, I think, okay. Patient had parvovirus IgM positive, IgG negative, slap cheek syndrome was there as well. What is your management? I'm so sorry, guys. Also, that's it's a recall question, right? So I'm not very sure of how exactly it was written in the exam, but this is the information given. Okay, so high cerebral artery indices. Okay, and history of parvovirus. What you need to do? Intrauterine fetal blood transfusion is a good option for treatment of the baby, but is it before or after 35 weeks? Before or after 35 weeks? You know what is the recommendation of the parvovirus guidelines? There is a guideline, Irish guideline for the parvovirus, right? And they would say that transfusion, okay, will not be very helpful after 34 weeks. Yes, delivery is a good option also, Dr. Asma, but is it now or by 37? What do you think? No, at 37 weeks. It's at 37 weeks, my dear. Okay. So the induction of labor should be at 37 weeks. So anything that I would do for the baby now to confirm the presence of anemia? Yes, the action line and the consideration for fetal blood sampling to Doppler. Yes. Okay. Why? Because based on that diagnosis, next step in action will be done. Okay. So yes, the answer is A, fetal blood sample. Okay. So the thing is, you have 35 weeks. 35 weeks, the value of the blood transfusion is not, okay, recommended. So this is already passed. I can deliver now if I have confirmation that the fetus is affected. But is it only by the Doppler? No, we need the fetal blood sampling as a good standard. Okay? So we have only a couple of questions remaining, my friends, of today's discussion. And here is a para 2 with high blood pressure, 135/100, with frontal headache. And the 24 hours urine protein is 3.2. How will you manage this case? Okay, so one said IV labetalol. So why, my friends, we will go for IV labetalol? Anybody knows? Okay, even if we have a severe hypertension, even in cases of severe hypertension, we will go oral. If the patient not responding or not tolerate oral, we go IV and so on. So the patient can start with oral, no problem. Okay, so why would you start the magnesium sulfate, my friends, at this level? To prevent fit. Okay, so what is the protein level in this case? Yeah, so yes, what they said for the diagnosis of the preeclampsia. Okay, so for the proteinuria, we can do it by the spot urine protein creatinine ratio, PCR, more than 30 mg per millimole, right? Or more than 300 mg per day, okay? Or at least 1 gram per liter on the dipstick testing, right? In the absence of proteinuria, okay, you need maybe evidence of maternal organ dysfunction, right? Or uteroplacental dysfunction along with the high blood pressure, right? Yes. Okay. So, yes. So, you do now have the evidence of the proteinuria, right? And you do have a high blood pressure with symptoms, right? Well done. Yes, of course. So now I need to manage this case. If I want to start for management of a case of preeclampsia, right? Shall I start with antihypertensive first or magnesium sulfate first? Who said that? Who said magnesium sulfate first? Look, my friend, first line management, I always have one of the candidate in each batch, okay, asking me or maybe a little bit confused which one to go. Is magnesium sulfate for the prevention of eclampsia first or it's antihypertensive medication first? Okay, so I would like to say that the first line, okay, of management, first line of therapy of preeclampsia is antihypertensive, please. Okay. Yeah, and I will send you just even for severe hypertension and preeclampsia, I will send you from the guideline and evidence to say that this is the first choice. Very clear in the Irish guideline. So the question now, will you go for labetalol IV or will you go for labetalol per oral? I can go by oral, why not? Okay, so very similar question to this one, okay, was coming in the EMQs for the MRCPI. And it's even found in Dr. Andrew Caesar book. Okay, so asking about, and also strategy. So it's a very common question that they ask. If you have to manage a case of preeclampsia, you start with antihypertensive, please. Okay, if the patient can tolerate oral and she is stable enough to take the oral medication, you will start with the oral labetalol. Okay, I go for IV when the patient is, for example, not responding to the oral, or the patient is severely unwell, okay, or the patient is in severe hypertension and she had a cannula, and you can start giving the IV. And by the way, the IV is not given fast, okay, it should be given very slowly and advised by even drip. Okay, so oral can help in this case, especially that this is not a severe one. If you come to the rule of the magnesium sulfate, yes, rule of the magnesium sulfate is very important in prevention of fits or in prevention of preeclampsia. I would give it next. Okay, friends? If I have a case with convulsions right now, then what I will do for the convulsions right now? Yes, so I can go for the magnesium sulfate. Why? Because the patient have fits, right? Otherwise, hypertension or diagnosis of preeclampsia, start on the labetalol, please. Even if he give you severe one, also start with labetalol. It's not only for mild or the moderate one. And here, second. Thank you very much, my dear friends. Yes. So one of the moderators helped me with a screenshot. 1 second. Yeah. Yes, yes. It's here. Okay, can you see it, my friends? Yes, you can give it for the prevention. My question, Dr. Asma, which one I will give first? Antihypertensive or magnesium sulfate? Which one you will start with in the management of preeclampsia? Which one? Which one, Dr. Asma? Antihypertensive first. Okay, so my friends here, this is from the Irish guideline. Okay, and it says for the management even of severe hypertension, this is the one that they send me. So the first choice agent is labetalol. So the labetalol is the first line therapy for treatment of severe hypertension in preeclampsia. Okay, and in severe cases, again, we can't give the IV, but if the patient can tolerate oral therapy, then initial 200 mg oral dose can be given. Okay, this should be lead to reduction in the blood pressure about half an hour. A second dose can be given after 30 minutes if needed. Okay, in hospital setting, we can think, of course, about the IV labetalol, but so far, okay, I don't even have severe hypertension. I am going for the oral labetalol choice. A patient with post-sleeve gastrectomy. This is our last question today, and next session we are going to continue. Okay, my friends. So we will stop at 20. Post-sleeve gastrectomy came at 12 weeks. Her current BMI is only 24. Previous weight was 129. What advice you will give her regarding this pregnancy? She was asking about the risk of the pregnancy. So pregnancy after bariatric surgery associated with risk of IUGR or small for gestational age or not? Yes, it is associated with a small for gestational age, of course. Okay, compared to the woman who doesn't have sleeve surgery, right? So the answer is A. For answer C, okay, I can see one of my friends advised C. Look, my dear, reassure her no any complications will arise since she had normal BMI. Is that logical? Can I just click this? Can you reassure no any complication will arise? No, never. Right? Okay, so it's proven that there is increased risk of small for gestational age in pregnancy following bariatric surgeries. Yes? Yes. Thank you very much, my friends, for attending today. I hope that you find a little bit of the information about the RCPI, about what type of questions can come, what type of resources can come. And I just want to show you in a practical way, okay, how to solve the questions, how to think MRCPI mindset, okay? Also, some point of difference are there, some common ground are there as well. Okay, and I would say, to be honest, is that the common ground is the majority. Okay, so good thing that you do have a common ground base between the MRCUG and the MRCPI. But of course, there are some differences, and the differences comes from the Irish guideline. So if our friends, the Irish people, have their own guideline, and you wanted to attend their own exam, then it makes sense that you just follow them, right? So once they have their own recommendation, in this case, this will be your reference for the answer. Otherwise, if the topic doesn't have an Irish guideline or no specific recommendation from the college, okay, the RCPI, then in this case, you will use the GTG as a reference. And you can see they depend on a lot of the GTG resources or NICE guideline resources, okay? But again, this is if there is no own specific Irish one available. Okay, my friends, TUG articles are common here and there, they are common. And don't forget that they cooperate together, okay? In the embrace, for example, they cooperate together in the auditing of cases or maternal and neonatal morbidity and mortality. So they have a common ground together. And it will be a very good chance, my friend, to give both exams. Okay, if you finish the MRCUG, you can go for MRCPI, or you can start with the MRCPI and then go for the MRCUG according to your own circumstances. Thank you very much, my dear friends. Thank you. Thank you, everyone. Answer last question. This is A. Risk of IUGR will increase compared to other women who don't have sleeve surgery. Okay, friends, thank you very much. If you needed any of the resources to study, or you are asking about any specific publication from the Irish publications, you can just request it in the group. Dr. Nada, thankfully, she is very active, mashallah, our mentor. She is going to help you. And I will be there also as well to answer all your queries. Thank you very much, my friends, for attending today.